Hi, my name is Caroline Laska. I'm a student at Maryville University in their doctorate program, and this is my scholarly project presentation on improving outcomes with diabetes education in type 2 patients. For the committee, Dr. Marie Snell is my Maryville University chair, and the second reader and community member is Kathy Rosenthal, nurse practitioner. So the background significance for this diabetes study is that diabetes is a chronic condition in which the pancreas produces little to no insulin, and it can cause many detrimental side effects such as skin ulcers, heart disease, strokes, kidney failure, retinopathy, just to name a few. More than 34 million Americans have diabetes, which is about 11% of the US population. And statistics do show that diabetes is on the rise and increasing in America due to sedentary lifestyle and diet, just to name a few things. Diabetes is a complex disease that requires up-to-date management and skills in order to care for oneself. Diabetes education is a tool that reduces risk factors associated with diabetes and can reduce complications, morbidity, and mortality. This is according to the American Diabetes Association of 2022. There was an extensive review of literature that was done for this study. 133 databases were used. Some of the names did include Academic Search Complete, Allied Health Literature, Cochrane Database and Systematic Reviews, EBSCOhost, Medline, and ProQuest. There were parameter restrictions included in the search that included full text, peer-reviewed English language, and anything published from 2016 to 2024. There was a large integrated literature review done. And the articles that were chosen were grouped into three themes: diabetes education, diabetes self-management, and glycemic control. And there were over 20 relevant articles that were reviewed, and an extensive literature critique was done on each one. Theoretical framework. So the theoretical framework is very important for the basis of the DNP Scholarly Project. The theory that was used was Havelock's theory of planned change. This was a theory that was created in 1976, and it created a process for change agents to organize their work and implement innovation in the work environment to help things run more smoothly in an organization and to help implement change into practice, essentially. Method, design, sample. So this was a quality improvement project in a large organization with diabetes education in the population. 50 diabetes type 2 patients were used. Prior A1C levels were assessed, and the A1C level shows how well their blood sugars were over a period of 3 months. So that's the time frame that we used. There was a pre-knowledge diabetes survey done before the education intervention, and a post-A1C level that was drawn in a lab was assessed after 3 months. Patients also tracked fasting blood sugars for more than 3 months, and a paired t-test was run on prior and post-A1C levels. This was done with the help of a statistician at Maryville University using Microsoft SPSS. Abstract. So the overall theme and purpose of this study was to develop quality clinical recommendations for diabetes education as an intervention in the adult diabetes population. So again, the background: diabetes education is essential to these patients. Education can lower fasting blood sugars and A1C levels. For the method, 50 diabetes type 2 patients, adults ages 18 to 89, underwent diabetes education. Pre and post A1C levels were assessed, as well as their fasting blood sugars that were tracked. For the results, a paired t-test that was run did show significance post-intervention. In conclusion, the education intervention did lower A1C and fasting blood sugar levels after 3 months. So again, I'd like to just let you know that diabetes is a chronic metabolic disease. It affects many Americans, and diabetes education is needed not only locally but throughout the US population. For this study, the PICO question that was used was, in patients with diabetes type 2, does diabetes classes versus no classes reduce the A1C and fasting blood sugar over 3 months? And again, 50 patients and participants with type 2 diabetes did undergo this study, and they were used as the sample. The aim of this project is to translate evidence into practice by developing guidelines and standards for diabetes education in this organization. So again, for methods, this was a quality improvement project that did shine light on the importance of diabetes education. All the guidelines during the intervention were followed with diabetes literature, reviews, and recommendations by the American Diabetes Association. 50 patients underwent the education, and pre and post A1C were studied, and morning fasting blood sugars were assessed, and patients took a pre-knowledge survey. Data collection involved patients taking the survey, having their prior A1C level examined in post, and the post one also was examined with the fasting blood sugar sheets. All the raw data was examined via Microsoft SPSS with a statistician. Many graphs and charts were created that included histograms, and a paired t-test was run on the A1C level results. All the results did show significant values pre and post educational intervention. Here are just a few graphs listed with the results. There were a lot of graphs created that are in the actual paper itself, but these are probably some of the most significant. So the figures below show the histogram and graph data for pre and post A1C levels to the intervention. So the first histogram does show the prior A1C levels, and the post A1C levels are to the right, and they do show a significant decrease before and after the study was done. For the analysis, data was in fact clear that A1C levels and fasting blood sugars were lowered post-education intervention. Just so you have some background, the paired t-test is a robust test that can allow for some violation without issue. The paired t-test showed significant. The p-value of less than 0.001 is less than the level of significance 0.05. Thus, this did show there was sufficient evidence of change in A1C from pre to post intervention. This was the paired t-test, one of the graphs created in SPSS with a statistician that did show after the statistics were run that there was a significance after the education intervention with the A1C, and it was a quite significant finding. Discussion. So the results did demonstrate many things. One, it demonstrated quality of the practice of diabetes education and how much it is needed not only at this organization but nationwide. The potential benefits of education to this entire population just showed that patients overall had better outcomes, and they felt better, had better numbers in every possible way. And also that there's a need for more diabetes educators and funding in the organization overall. There also needs to be more awareness around diabetes education in the organization and across the nation too. Diabetes education can not only make the patients have better outcomes, but can ultimately decrease admissions in the hospital and have the patients just lead healthier lives all around. So there were many strengths to this study. The most important one, obviously, is that it lowered A1C levels and fasting blood sugar levels in these patients. There are proven health benefits of education and better outcomes. Also, there was an increased awareness among patients, staff, and clinicians while this study was underway at the organization. Of course, there were some limitations to the study. So all patients were diagnosed as type 2. However, some were undergoing antibody testing during this study, which means that they could have been type 1, but they were undergoing the testing at the time of the study that they got the education. Now, this doesn't mean that diabetes type 1 patients can't benefit from the study. In fact, they also benefit greatly from diabetes education. It's just the specific focus for this study was on diabetes type 2 patients, not type 1. Although they did benefit, their diagnosis may not have truly been type 2 for some of them. Also, some patients did not turn in their blood sugar logs correctly. They were blood sugar logs that I had created for the study. They didn't turn in those ones specifically, but they did turn in other forms of data in which we could look at their fasting blood sugar levels. An example is many diabetes patients use higher technology rather than the old-fashioned pen and paper writing down their blood sugar levels. They use things such as Dexcoms, Libres, Guardian sensors. You wear them on your arm. This sits on your arm and tracks your blood sugar in real time. Patients are able to upload a PDF to the office, send it over through MyChart. So we get data that way, and that is actually how the endocrinology practice usually gets data from patients rather than the old-fashioned way, and some of them are so tech savvy that that's how they got it to us. So I did still take into consideration, I used their numbers for their fasting blood sugars that way rather than the tracking sheet that I had given to them. So it still was data, but it wasn't the data that we asked for and how to track it. So it was a little more complicated going through those PDF sheets, looking at their blood sugars per se. And also some of them did send in some of their data late. So nonetheless, we did get it, but some of it did ultimately come in at a later time. So again, I did say it before, but in conclusion, diabetes education does significantly lower A1C levels and fasting blood sugars, and it also decreases complications in these patients and decreases mortality and morbidity. It's an essential tool and intervention needed for the diabetes population, including type 1 population. So type 1 and type 2 greatly benefit from it. And in other studies, we could get into how it can affect prediabetes as well. But this study just solely looked at type 2 diabetes. There does need to be further awareness and funding implemented for diabetes education across the organization. Unfortunately, we only have 2 diabetes educators who cover 2 hospitals, 5 outpatient clinics, and we have such a large, robust diabetes population that we need more funding, more educators to really get in there and help with education across the spectrum. Implications for nursing practice. So the project does demonstrate the need and urgency for increased awareness and funding for diabetes education in the organization. So although our educators are great, we just don't have enough to keep up with the population. And this is something that needs to be addressed at all levels throughout the organization, that we do need more funding. We do need to hire more educators to help educate these patients, to decrease complications for these patients and decrease hospital admissions. We're very, very busy practice and staff are overworked, clinical staff is overworked. If these patients had the proper tools and education to care for their diabetes at home, their diabetes levels and numbers can be decreased drastically and their complications would be very low. Patient outcomes depend on enhanced learning and good home diabetes management. Home diabetes management is essential for this population, and there needs to be more awareness and more tools for these patients in order for them to flourish and to control this disease, and in fact maybe even reverse diabetes type 2. It is something that is just crucially needed, and there needs to be more awareness, tools, and funding. Future research. So extending understanding of this project is very beneficial to patients and the organization collectively. So again, diabetes education decreases morbidity and mortality in these patients, helps reduce numbers, also helps them to lead healthier lives. It reduces ER admissions to the hospital and helps the hospital to save money. So all around, it's a great tool. So this is something that will be looked at and presented at the higher administration levels in this organization to make the case for further funding for diabetes research. That includes more funding and educators specifically at this organization. So I do definitely think that not only the higher ups, but other clinicians and practices throughout the organization can benefit from hearing about this study. And also just, further working with even bedside nurses and their understanding of diabetes education when patients are discharged. There's many different levels of things that we can work with this specific study in the future research of diabetes education. There are many future studies that I actually think could greatly benefit from diabetes research and studies. Some of them may address further barriers to education. Some barriers may include patients who can't leave their home because they don't have transportation. Maybe it's hard for them to get there. So maybe looking at more virtual, higher technology ways to make sure that they get education in other ways if they're not able to leave their house and come in. So there are a lot of great technologies that are coming out more and more every year with diabetes. And I think just implementing more technology and higher technology in organizations can help patients a lot. So these are just some things like newer innovations can help with the diabetes population. Also, again, a lack of funding and resources, especially in the organization where I am. There are 2 educators who are spread pretty thin, and we have a very large population. So having them teaching these classes individually or group classes, they're spread pretty thin. Then having to cover 2 hospitals, trying to do education there, it's a lot for them. So I think if the organization realized how robust our population is, how little educators we have, and how little classes that we offer, it would be very eye-opening to them because, again, patients do benefit from diabetes education greatly. So if we could get more funding and more resources in order to have more educators, I think that this is something that can really be greatly beneficial to our future with diabetes research. And again, increasing technology. There's a lot of technology out there, smart pads, iPhones, a lot of diabetes technologies are ramping up future innovation. For example, Libre meters that sit on your arm that are paired with your smartphone, and even older patients have these. So they're keeping up with the technology. So I think there could be a study that includes patients who undergo virtual training with education. How does that work? How does their A1Cs look before and after that? Is this something that will help with further education in the future? These are just things that, I'm thinking of that could be future research that could be done in the future. And also, again, enhanced training of clinical staff. So yes, a lot of clinical staff, RNs, nurses, doctors know about diabetes. But when it comes down to it, if somebody is brand new to diabetes, it is a very complex disease to manage at home. So they really need to know how to teach these patients about diabetes and give some education themselves, maybe about the disease itself, how to give insulin, how to track sugars, what to do with highs and lows. So if we can maybe enhance the training of the staff, I think that would be a great future research study. Training more nurses maybe at the bedside, so if somebody who's going home with diabetes on discharge, they could do further education, and maybe we can look at their numbers with that. Does the nurses teaching do well? Do the patient's numbers do well after they're discharged from the hospital? This is another type of study that I think would be really interesting to look at in the future, and really the sky's the limit with diabetes education and research, because there's so many new things coming out and there's such a robust population. There's numerous things we can look at for research, and I would be very happy to be involved in these studies and really look forward to it in the future. So, in a nutshell, that is my presentation on diabetes education and diabetes type 2 patients. I wanted to leave this slide here and ask if anybody had any questions. And if you do, please feel free to reach out to me or email me and let me know what further questions you have that I can address that I didn't address here on the slideshow. I'd be more than happy to address those questions. And here is my reference slide. I thank you so much for listening. And again, please reach out with any further questions. Take care.